Welcome back to the RX class. I'm your host, Dr. Guang Chen. Recently, I sat down with Dr. Ken Liu. I've known Ken for more than 20 years. He's a great hepatologist and transplant physician and has looked after several of my patients with advanced liver disease. Ken is clinical associate professor at the Sydney Medical School Central Clinical School, a staff specialist at AW Morrell Gastroenterology and Liver Centre at Royal Prince Alfred Hospital, Sydney. Ken is a clinician scientist and a staff specialist transplant hepatologist. Prior to becoming an attending consultant, he completed his residency in internal medicine, gastroenterology, and hepatology in Sydney and Hong Kong. Ken also completed a PhD in liver cancer. The PhD was awarded an NHMRC postgraduate scholarship and Peter Bancroft Prize for Research. Please note that throughout the podcast episode, the information presented is general in nature and use at your own risk. Complex concepts may be oversimplified for entertainment purposes. Symptoms and medical conditions, as well as the diagnosis and treatment of these conditions, may be mentioned. The information presented does not constitute the practice of medicine nor replace medical advice from a licensed medical professional. Do not rely on the information to make decisions about your or someone else's health. Please seek help from a certified health practitioner if you have concerns or symptoms. Please enjoy my conversation with Dr. Ken Liu. Well, welcome, Ken. Thank you for coming on the podcast to chat with me today.
Oh, thanks for having me. It's a pleasure.
Well, Ken, please tell us a bit about yourself and how you got to where you are today.
I'm a liver transplant physician. That means I'm a liver specialist. And to get to where I am, I did med school like everyone else, and then internal medicine training. And then I decided to specialize into gastroenterology. And within that, there are several subspecialties, of which liver or hepatology is one of them. But then you might have heard of other people doing inflammatory bowel disease or advanced endoscopy, but I chose liver. And every hospital would have a hepatologist or someone with a liver interest. And because I work at Royal Prince Alfred Hospital, a liver transplant hospital, and I not only look after patients with liver disease, but also people who've had liver transplant. I don't do the surgery, so a lot of people ask if I'm a surgeon. There's a separate person who does that. They're surgically trained and they do the operation, but I look after people with liver disease heading into transplant and coming out of transplant lifelong afterwards.
Would you say the liver is your favorite organ of the body?
Yeah, I think so. It certainly is the most interesting for me, and yeah, it certainly gets me out of bed, and I look forward to coming to work.
For the people at home, can you describe, I guess, what is the liver and what are some of its functions and how you think about it in terms of its overall structure and position in the body?
Sure. So the liver is one of the organs that sits in your abdomen, and it's on the right side, just under your diaphragm. And everyone gets just one. So everyone has two kidneys, or most people have two kidneys, but everyone just has one liver. And it actually does quite a lot of different functions. So the one that most people will be familiar with is the liver is the organ that metabolizes and detoxifies things that you ingest. So the food that you ingest, the medications that you take, that all go into the guts. That gets digested in the stomach and makes its way through the intestines, and whatever gets absorbed through the blood, all of that blood has to filter through the liver before it gets to the rest of the body. And it's the liver's job to turn that into useful things. And the other thing the liver does is it makes essential proteins. So one of the main ones is called albumin, which is the major protein in your blood, and that serves multiple purposes, but it helps keep fluid or plasma inside your blood vessels. So the liver is quite key in regulating fluid throughout your body. The liver also makes bile and excretes bile to help you digest food. So this is why if you have liver problems and bile builds up in your body, you can look jaundiced. And I guess another major thing the liver does is it makes a clotting protein, so it helps your blood clot when you have a cut or when you bleed. A lot of those proteins are made by the liver as well. And overall, the liver is also like a lymphoid organ, so it contains immune cells, which can help you fight infection as well.
And you've mentioned all these complex functions. So does that mean that we can't survive without our liver?
Yes, that is true. So everyone needs a liver to survive, and if you don't have one, then you'll be dead within a few days, basically. That's, I guess, unique in terms of other abdominal organs. So, for example, if you had no kidneys, you can be kept alive with a dialysis machine, or if you had no pancreas, you can certainly survive without that. And of course, you can remove at least large parts of your intestines or your stomach and even your spleen and still live a fairly normal life. Whereas the liver, you certainly need that to survive. You don't need all of it. You can cut out even up to beyond half of your liver and still be able to live. But you certainly need a mass of liver cells to do all the jobs that I've mentioned before to survive. And you might ask, well, is there some kind of equivalent machine like dialysis for the kidney that there is for the liver? And although many have tried, there's not been a single machine that's been good enough to stand alone do the job of the liver. So this is why people need transplants. And yeah, there's no equivalent machine like a dialysis machine where you hear of people in renal failure that can live many years, even decades, on dialysis. That just doesn't exist in the liver.
So today, what are the most common causes of, I guess, liver damage?
Yeah, so if you're just talking about liver damage overall, and what I mean by that is damage to the liver such that it's inflamed, then probably the most common cause is fatty liver disease. We live in a society which is 2/3 either overweight or obese, increasing rates of diabetes, and all of that, these metabolic risk factors can contribute to you having fat in your liver, and the liver generally doesn't like having fat there, so it becomes inflamed. And that might manifest in abnormal liver tests, in blood tests. Most of these people are asymptomatic. But if you're going to talk about what is the most common cause of liver damage in terms of it being so severe that people need liver transplant, then at the moment it probably is alcohol, along with people having liver cancer, and certainly fatty liver disease is also rising. And then there's this group of other liver conditions which are caused by your immune system being overactive, so autoimmune liver conditions. But overall in the world, fatty liver disease is the most common disease, probably followed by alcohol.
And I guess how do you, I guess, think about the damage, and how do you categorize it in terms of who would you consider being mild, moderate, and severe, and at what times or at what time points you would, I guess, consider a liver transplant maybe better versus the standard care?
Yeah, so I guess there's two different types of liver injury. One is an acute type where people get really sick really quickly, and then the other is more like a chronic grumbling type, which happens over many years or decades. So, for example, the acute type, fatty liver is not going to cause you to have liver failure or decompensated disease where your liver's not working properly within days, weeks, months, or even years. It tends to work over decades. Whereas if you, for example, took a large dose of Panadol that's way beyond recommended levels, then your liver can become acutely unwell. Or if you had a really bad virus infection like hepatitis B that was causing your liver to be very, very severely inflamed, that can cause quite severe liver damage acutely, such that people's livers are failing and they need transplants quickly because of that. That would be less than 10% of our liver transplants. Whereas the most common type are the people who have chronic grumbling liver damage. That day to day, they're asymptomatic, they don't notice, but through many years of accrued damage, then they become cirrhotic. I'll explain what that means in a sec. And then their liver decompensates, needing transplant. So for those people, the people with chronic injury, how you determine how severe it is, it's generally governed by how much scar tissue or fibrosis there is in the liver. So what happens when the liver is inflamed is it heals by laying down scar tissue. And the more scar tissue you have, the more severe your liver disease is, and hence the less healthy liver cells there are to do the jobs of the liver. And when you get to a certain amount of scar tissue, we call that cirrhosis, or that patient is cirrhotic. And when a person first becomes cirrhotic, you wouldn't know. Like, you walk past them in the street, you couldn't tell the difference. That's because the liver is compensated. So remember, I said in the past you could survive on a fraction of your liver. So if a lot of your liver is damaged, you can still survive and have no symptoms because the remaining healthy liver cells work extra hard to keep doing the job of the liver. So if you imagine the liver is a factory and you laid off half the workers, the factory will still run because the remaining workers still pick up the slack. And then if the underlying cause of liver damage keeps going, like you keep drinking alcohol, or you're still having fatty liver disease, or your hepatitis B or C are not controlled, then at some point you would have lost too many workers, and the factory just simply cannot keep working at capacity, and it will start failing. And that's when people become decompensated. And that's when you will notice that someone has cirrhosis if you walk past them in the street. So, for example, they might appear jaundiced, as I mentioned. They might carry extra fluid in their abdomen or in their legs, and they might have lots of bruises or clotting problems. And in the very severe end, because the liver clears toxins from the gut, and if those toxins go straight to the brain, then you could get confused. So they might appear confused because of liver failure.
And so would you say those are the, I guess, telltale signs of when the patient might require transplantation? When those
Yes,
end organ, I guess, effects come to the surface?
that's right. So I think with compensated cirrhosis, you pretty much live a normal life, and you see your liver specialist every 6 months or twice a year. Whereas when you become decompensated, that's when you're starting to think, oh, does this patient need a new liver in order to keep surviving for a long time?
And what is the process of, I guess, potentially getting a new liver? Is that a very long process? Is it involve many tests and appointments?
Yeah, so I guess it depends on how acute the problem is. So if you're, one of those rare cases where you got acute liver failure, you're usually in hospital in intensive care even, then those people get referred to us via an inter-hospital transfer, and then we would do all the what we call a workup for liver transplant, all the tests that you need for us to know that you'll survive the operation, all done as an inpatient and quite quickly, so that we can put you on the waiting list. In the majority of people with chronic liver disease or liver cancer that need transplant, they would usually see local specialists, usually a gastroenterologist or a hepatologist, and they're managed initially, and then when they become decompensated to a certain degree, and they otherwise don't have any reasons not for transplant, then they get referred to me as an outpatient. And then I would, I guess, depending on how severe their liver disease is, I would book the appropriate appointment for them. I'd meet them, and then I would assess, whether there's any chance I can turn this liver around without a transplant. And if the answer is no, then I would also commence a workup. And if you do it as an outpatient, that might take 2 or 3 months to do all the necessary tests as an outpatient before we're able to list them on the waiting list. And then once you're listed on the waiting list, the waiting time really depends again on how sick you are. We don't have the luxury of keeping people alive on dialysis for long periods. So the sickest people are at the top of the wait list, and the less sick people are towards the bottom. Whereas in renal transplant, it doesn't work that way, and the duration of time that you've been waiting actually is factored in terms of how high up on the list you are. Whereas in liver transplant, we use scoring systems and whatnot to prioritize people from least sick to the most sick.
And so, I guess on average, for example, if you're very sick, how many days would you be waiting? Days and weeks, and then if you're not so sick, maybe weeks to months. Is that the average wait times?
Yeah. So if you're in acute liver failure, what would happen is, because you wouldn't survive beyond a few days or a week without a new liver, we would list you nationally. What that means is any organ donor that dies within Australia and New Zealand, that organ it has to be offered to my hospital with an acute liver failure patient first before it gets used locally. So whereas if you're not in acute liver failure and you're being transplanted for a chronic reason like decompensated cirrhosis, then those people in general can only get access to New South Wales, which is where I work, grafts. So if a donor dies in New South Wales and that person is the same blood group and a size match for my patient, and they're at the top of the list, then they get that donor. Whereas if a donor dies in Queensland, for example, we would not get access to that. But we would if it was an acute cause of the liver injury, because those people are much sicker.
And what are the common, I guess, reasons that you would exclude patients from transplantation? Is it due to their age or other medical problems?
Yeah. So I'll deal with age first. There's no absolute age cutoff per se. So what we deal with is physiological age. So you could be a marathon runner at age 75 and do well with a liver transplant, or you could be quite a comorbid 50-year-old with lots of complex, severe medical issues aside from your liver, and you do badly with a transplant. So we've transplanted people all the way up to 75. I think like beyond that is really pushing it, because when you do get older, you deal with stresses less well, and you are at higher risk of complications post-transplant, of which there are many, and you just don't deal with them as well, and there's a higher chance that the liver transplant won't work. Whereas when you're younger, you tend to be more resilient and deal with complications better. So yeah, I guess it would be more ideal if the patient's under 70, but that in itself is not an absolute cutoff. If you have an active infection, like at the time of transplant, then we would say no, because after transplant, everyone gets put on immunosuppression, or else your immune system will attack this foreign organ that's come from some other human to protect itself. So if you suppress your immune system with drugs, then you can't fight infection very well at all. So if you have an active infection, we usually say no at that point until the infection is resolved. Similarly, if you have a cancer that's active, apart from liver cancer, because you're swapping out the liver, but if, let's say you have active breast cancer or lymphoma or bowel cancer or something like that, again, there's no absolute rules, but in general, we would like that cancer to be dealt with before we transplant you, again, because you need the immune system to fight cancer. And if you're put on drugs that suppress the immune system, then those cancers can become quite hard to deal with. That's not to say, though, that that's not an absolute rule. So, for example, I've transplanted a patient with breast cancer once because they didn't know they had hepatitis B, and they went on to chemotherapy, and the hepatitis B became really severe, and they went into acute liver failure. They're going to die without a liver transplant, but they also had breast cancer. But in that particular setting, that breast cancer was a very early stage and very curable. So, straight after the transplant, the patient had the breast cancer cut out, and it was dealt with really quickly. So, I guess they're just some what I call relative contraindications. And then there are things like about your general health. So, for example, if you have really bad cardiovascular disease or your lungs are very bad, where it's risky for you to undergo this intensive 4 or 5 hour operation and you might die on the table, they might be a contraindication to you having liver transplant. And then aside from the medical things, there might be social reasons. For example, if you don't have good social support and you're not good with taking your medications, or it's highly likely that you'll go back to drinking alcohol after transplant, they might be reasons why we say no as well.
And so what actually happens during a liver transplant? You said it takes 4 to 5 hours.
Yeah, so I'm maybe not the best person to answer that, but I'll give it a crack. Since, as I mentioned, I'm not a surgeon. So what happens is a donor dies, and then they're usually in ICU, and they, during their lifetime or their family, have expressed a wish to donate their organ. And the local hospital, wherever they are, will then perform a series of tests on the patient to declare them as brain dead or not. And they'll test various things to check if their organs are healthy enough to be donated, such as like their liver and kidneys and heart and lungs, etc. And then a very detailed document about that patient is sent out to the various people on call for the different organs. Let's say I'm on call for liver transplant, I would get a phone call saying, listen, we have a donor at this hospital, they're this old, they're this sex, they weigh this much, these are their medical problems, this is how they died, this is what their liver tests look like, etc. And then I decide, well, is this organ good enough or not to be used? And I guess one of the most common reasons I reject is because the liver might be too fatty to begin with. I mentioned that fatty liver disease is one of the most common causes of liver injury. It wouldn't make sense for me to then put a fatty organ into a patient who really needs a healthy organ. But suppose the liver is good enough, then I look down on a list of patients who need transplant, and then the most important thing to match is the blood group. So a blood group O donor goes into a blood group O recipient, A into A, B into B, AB into AB, etc. Occasionally, when we're desperate, we do offer organs that are cross blood groups. And then the next thing you look at is the patient's size and whether the organ's large enough or not too large for them. And then once I choose the recipient, they get a phone call and they come into hospital, where they again get assessed whether they're fit enough for transplant. In particular, do they have an active infection at the moment? Are their blood tests safe for them to proceed with the operation? And they come into hospital before the donor is even opened up. right? Because just to get them prepared for surgery and to get them fasted. So while they're waiting in the emergency department, waiting for the operation, the donor surgery is planned at the donor hospital, and we send a team of surgeons to go and retrieve the organ. And it usually happens early in the morning so that the liver transplant starts in the morning during daylight hours. So at 4 or 5 a.m., the donor gets opened up, and the donor surgeon retrieves all the organs, and at that point, the donor surgeon also has a look at whether the organ's good enough or not. Because on paper, you could have a guess as, oh, maybe this organ will be too fatty or not good enough, etc. But you never really know until you open up the patient, the donor. So there are times where the recipient's already called in, they're being told, oh, there's a potential of you having transplant today, and then a few hours later we open up the donor and the liver doesn't look good enough, so we cancel the transplant. Okay, so if the donor organ looks good enough, then it gets retrieved and gets brought back to Royal Prince Alfred Hospital for the liver transplant surgery. So once we know the donor liver is good, the recipient gets opened up and they start the operation to free up the old liver and to remove that while the new liver is on its way even. And there's actually quite a few joins in the liver. So for example, the liver has its two different blood supplies, one via the liver, an artery, another one with a vein. They both supply blood to the liver, and then a different vein takes blood away from the liver. So now we're dealing with 3 different blood vessels that need to be cut and joined. And then the liver also has a bile duct, which excretes bile, which needs to flow into the intestine, so that needs to be joined as well. So there's, broadly speaking, there's at least 4 different joins that need to happen: the hepatic artery, portal vein, hepatic vein, and the bile duct. So it is complex surgery, and because a lot of the blood that goes from the intestines has to go through the liver before going back to the heart, there's a period where you have to clamp the blood vessels while this operation is happening, so that not too much blood is lost. And then after that, the operation happens and the patient gets closed, and they go to ICU for the first few days to recover.
And what happens during the recovery? They're just having bed rest? Are they on special diets? Do you start the medication straight away in terms of the rejection medications?
Yeah, generally within the first 24 hours, they would get rejection immunosuppression or anti-rejection medication, and they come out to ICU, usually intubated, so with a breathing tube, and on various different medications, and there's drains that come out of their abdomen to drain out ongoing oozing blood, and they have various different lines to give them medications or fluid through their neck. They have a catheter to empty their bladder. So they come out like with lots of different paraphernalia being stuck into them, and then with each day, that gets less and less if the transplant's going well. So they usually get extubated, so the breathing tube comes out. So then they wake up, and then if the drains, not much blood is coming out of them, and the bleeding from the operation stopped, then the drains come out one by one. When the patient's sitting out of bed more, we take out the catheter so they can go and pee in a pan or go to the toilet, and then we replace the central line which goes into their neck with a cannula that goes in their hand. So it just becomes it just morphs in from an ICU patient to be someone that you might see on the ward. And that process, it really depends how sick the patient was leading into transplant. So if someone's coming in from home and not that sick, that might take a couple of days, and then they're out onto the ward. Whereas if you're very, very sick leading into transplant, then you usually have to spend more longer time in ICU and afterwards longer time in hospital just to recover before you leave. In terms of diet, most people are nil by mouth when they come out, and then once they get extubated, the surgeons decide to start a diet. That might be supplemented with extra feeding through a tube that we put into their nose that goes into their stomach in the first few days. And then once they're eating and drinking well, that diet gets upgraded to solid food. And by the time they leave, they're eating normal things.
And so, on average, if things go well, they'll be back home within 2 weeks or 4 weeks
Yeah.
of.
Our average length of stay is 18 days after a transplant. So that's just under 3 weeks. But that's an average. So if like I said, we've had patients stay for months after transplant because they've had lots of complications. We've also had people discharged within a week because they've just sailed through the post-operative recovery. But yeah, on average, I would expect 2 to 3 weeks in hospital, the first 3 to 5 days in ICU, and then the remaining time we have a special ward at our hospital which just looks after transplant patients, so liver and kidney transplant.
Look, I mean, I guess it's reasonable, I guess, for patients to live close to the hospital. But as a transplant unit, you service all of New South Wales, which, for people who don't know, is a very, very large state in Australia. And I presume you have some patients who are coming from rural or remote areas as well.
Yeah, that's correct. And so the beauty of how the whole donor thing works is we usually get a call the day before, and then we can plan out everything. So once the recipient's chosen, there must be a good 12 hours before they actually have the operation. So we can time things to get enough time for the recipient to come in. So this includes chartering so let's say they live in rural New South Wales, then we might have to get them on a commercial plane to come to RPA and to allow enough time for that. Or some people might live close enough to that they can drive, or 2 or 3 hours to get here. Very rarely we do charter a private jet to get them to hospital in time. Just like sometimes when we go and retrieve an organ that's in a remote area, we may need to send our own jet to get it. But it's such a. I will say that there's like a team of logistics people who sort all of that out. They're not things that I would have to worry about.
And so, how many transplants are conducted, I guess, in New South Wales or at RPA per year, and how many are there, I guess, across Australia?
So we're the largest liver transplant centre in Australia. We do somewhere between 80 and 90 adult transplants a year. And don't forget, there are children who get transplanted, and that liver transplant unit is at the Kids Hospital in Westmead. So between us and Westmead, combined adults and children, we would be close to 100 people who get liver transplants per year. And that's the largest in Australia. And in any given year, there's roughly around just like over 300 liver transplants that get conducted across all the other states. So across the whole of Australia, about 300.
And how many patients will be on the waiting list? Roughly, was it a 1-to-2 ratio, a 1-to-3?
So yeah, in total, there's probably somewhere like between 40 and 50 in New South Wales anyway, 40 and 50 people on the wait list at any time. There's obviously that number ebbs and flows. So on average, as I said, we do 80 a year. That's about 1.5, so between 1 and 2 transplants a week. But some weeks we might do 3 or 4. Some weeks we might do none or one. So the number on the wait list can vary, and there's certainly people. I get new referrals every week for transplant to be worked up as well. So yeah, I would say that the demand certainly outweighs the supply. So we're always in need of more donors in Australia, and the people on the wait list, they certainly need liver transplants. But I would think that there's a lot more people in the state who with severe liver disease or liver cancer that would usually need a liver transplant, but they're not necessarily being referred. So I think there's all these people who might benefit from liver transplant that I don't even know about in the state.
And how do you, I guess, how can people at home, I guess, help the situation? How does one become an organ donor? And is there any paperwork to do, or is it just an online form?
Yeah, so you the easiest way is to just register online. There's this website called Donate Life where you can join to be an organ donor. A lot of people think, oh, if I tick the box on my driver's license application that says I'm willing to donate, that's it. Well, that's not it at all. To formally register, you need to do it on the website. And it's also helpful if you're going to do that to inform your next of kin or your close family members to let them know your wishes. Because suppose you unexpectedly get really sick such that you're not going to survive, and you have registered to be a donor, we would always check with your family and get their consent before we proceed. So you could, register as an organ donor, but if your family don't know about it and they get asked and they have other views than you on organ donation, and they don't give the consent, then your organs would not be used. It works the other way around as well. If you didn't register and you didn't sign on the website, but you get really sick, needing and you're about to die, they would also ask your family, would organ donation, would that have been something that you would have done? And then they make the decision on your behalf. But obviously, that decision would be made much easier if we knew that you already registered while you were alive, and you weren't intubated and you were able to think for yourself, and that during that moment of clarity you decided to register yourself, and therefore it makes it much easier for the donation specialists to approach your family and say, hey, these were your family members' wishes. They wanted to donate, and more often than not, then the rest of the family will agree.
Yes, I agree. Everybody, I guess, who want to donate their organs should register and let their family know. Look, I mean, we briefly talked about, I guess, the lack of organs. Do you see any other major challenges with, I guess, liver transplantation or organ transplantation at this stage, and whether things are evolving or changing and new advances will be coming in the next 5-10 years?
Yeah, so I guess there's two ways to solve this supply and demand problem. One is to look after liver disease in the community really well, such that patients never need transplant. I always say to patients, if we can avoid you needing liver transplant, that's always much better than proceeding with a transplant. So, for example, a lot of liver diseases are silent, and you may not know that your liver is inflamed or has fibrosis in it unless you specifically tested for it with your doctor. One condition is hepatitis B. If you come from an area which is endemic in hepatitis B and you haven't been checked, then you should get it checked, because there's good, easy treatments for that to keep your liver healthy. If you live a healthy life and keep your weight within a healthy range, and you don't have diabetes, high cholesterol, etc., then that should prevent you from having fatty liver disease. If you don't drink alcohol to excess, or if you did and you stop drinking, then that can, certainly keep your liver healthy enough not to need a liver transplant. So all of these, like prevention is always better than going for a transplant, right? So what we saw when the new hepatitis C medications came into Australia in 2016 was, prior to that, hepatitis C was by far the most common indication for people needing liver transplant. And then through the course of a few years, with these new drugs where you take tablets for 3 months and you cure your hepatitis C, a lot of those patients, their livers became healthier and they avoided transplant. And we saw quite a dramatic reduction in the number of patients on our wait list. So yeah, I guess one strategy is to look after liver disease well. So that means testing for it in people who might not know they have it. And once you identify people with liver disease, then giving them active treatment, whether that's antiviral medications or weight loss regimens, or stopping alcohol, etc. And then I guess the other prong is trying to improve our supply, so increasing the number of usable organs that we have. And certainly one approach is to increase awareness about organ donation so that more and more people are willing to donate their organs. And two is, the majority very few people die young, fit, and healthy. Why would they? Unless it's some tragic accident, like a car accident or something like that. So therefore, the majority of our organs come from older people, and they might be, overweight or obese, or they might have diabetes, and their liver might be fatty. And we call those organs. So if you're over 65, or you're obese, or that we call, and you were to donate your liver, we would call your liver a marginal organ, and therefore they may not work as well in the recipient if we were to put in a marginal organ. But nowadays there are all these things called machine perfusion, which can improve a particular organ in terms of its transplantability. So usually what happens at the moment is, when we take out an organ from the donor, we infuse it with a preserving agent through the blood vessels, and then we just put it on ice while it's traveling to the transplant center. And that can help preserve the organs to a certain extent, but the longer the time happens, more and more cells are dying, so that organ becomes less and less healthy. But with new technology, what happens is we can hook these organs onto a machine, which constantly pumps it with nutrients as if it was living inside someone's body. And we've in our unit, we've been able to keep a liver alive on a machine for in excess of 12 days. And during that time, you're sort of reconditioning the organ to be more and more healthy, so that you can transplant it into someone. So you could take an organ that we would otherwise discard because it's too fatty, or the liver enzyme, like it's too inflamed or whatever, put on a machine and replenish it, and turn a discarded organ into a usable one. And I think that's been one major advance in the liver transplant field in recent years, so that organs we used to discard are now usable, and that's also increasing the donor pool that we have to help combat the increasing demand that we need for liver transplant.
And what about, I guess, newer technologies? I presume 3D printing is a long way away, or using xenografting, so using another animal species. I guess using pig
Yeah.
organs.
So I think those are all, I guess, feasible things, and potentially in the future they might become a thing. So certainly xenotransplant in There's been recent data, for example, in kidney transplant that's seen as promising, but at the moment it's still quite experimental. And yeah, then I think if we can really look after liver disease well and also boost our organ donation and organ utility, we may never need to reach for those things. But yeah, at the moment, I would say that current practice, those things are not used at all or considered outside of a laboratory setting. And if I was to make a prediction, I think even in my lifetime, they probably may not become standard practice. But yeah, who knows? I could have said, the same thing about hepatitis C treatment 20 years ago, but now it's quite easy to treat.
And I guess for people at home, is there a simple test to check for your liver health? Is it a blood test that you can get from your family doctor or a scan? Um,
So I think the first thing you could do is a simple blood test called the liver function test. That will test if your liver enzymes are elevated, which suggests your liver might be inflamed or not. And then if it is inflamed, then there's a very simple calculation you can do on your blood test to figure out or to estimate how much fibrosis there is. So based on your age, the number of platelets you have in your bloodstream, and the degree of your liver enzymes, we could figure out, well, are you someone with lots of fibrosis or not much at all? And if you have not much at all, then you can stay with your GP and work on your liver health with them. Occasionally, that test is a bit indeterminate, and there's a very simple ultrasound test called a fibroscan, where it measures how stiff your liver is and hence how much scar tissue there is there, and that will give me an idea of how severe your liver disease is. In general, if the people who need to see a liver specialist are those on the more severe end, so they have quite advanced fibrosis or cirrhosis. Whereas if you have milder versions, then you can stay with your GP. Yeah, something I might also touch on is a lot of people would ask me, what are the success rates of transplant? So the numbers I quote are at the 1 year mark after transplant, about 95 out of 100 people are alive. So that means 5 people in that year will have died from complications from the transplant. At the 5-year mark, that's about 85%, and at the 10-year mark, 75%. And they're figures in Australia, which are pretty much on par with elsewhere in the world. And you might decide, well, actually, if you told me I had a 75% chance of being alive in 10 years or 25% chance of being dead, they're quite, low figures. That's not very good at all. But you have to bear in mind that these patients who need liver transplant, they're quite ill, and they might not have a 75% chance of being alive at 10 years. So, they rather take the risk of having the transplant, those odds, than what they would have with their current liver. And there are sort of objective scoring systems we use to sort of gauge, well, are you better off with the transplant or without? But in general, I think you were asking me before, how do you decide if a patient should or shouldn't have a transplant? The general rule we use is if your 5-year survival is going to be 50% or more, then it's usually worth pursuing. So that means, let's say, my examples where you had a recent cancer, or you have cardiovascular disease or various comorbidities. Well, is that bad enough to contraindicate you to having transplant? Then we sort of use the 50% at 5-year rule. So if your cancer is a really good prognosis cancer, it can be cured or controlled, such that in 5 years' time your risk of being alive is more than 50%, then we would transplant you. Same if you had some kind of heart or lung issue, if it was good enough to get you through to the next 5 years at more than 50%, then we would that would be our threshold to transplant.
I guess for people who are interested, it's probably best to speak to their family doctor and their specialist to get more information. Thank you again, Ken. I guess hopefully we'll catch up again next time.
No problems. My pleasure.